Implementation of music. Oh,
everyone.
Good morning. Good morning, Dr. Amit. Please start करिए.
Good morning.
Good morning, everyone.
Good morning.
Good morning. Good morning. Good morning, sir. Pranam, sir.
Pranam.
Good morning, Dr. Gupta. Both of them. Good morning, sir.
Good morning. Good morning, everybody. Good evening to Miraji.
Good evening, ma'am. Ma'am, please unmute yourself. Ma'am, please unmute yourself.
Good morning, Gupta sir.
Yes, good morning.
Okay, ladies and gentlemen, we are about to begin the workshop. I would request everyone to keep yourself on mute mode to avoid any kind of interruption. Thank you.
Okay.
Honorable guests, respected speakers, ladies and gentlemen, a very good morning to all of you. I believe that you all are doing safe and healthy during this pandemic. Thank you for joining us for this important event. Let me introduce myself. This is Renu Sharma, working with the Union Southeast Asia office as a project officer. Also, I would like to introduce my co-host, Dr. Nidhi S. Puranik, Senior Technical Advisor of the Union. On behalf of the Union, I would like to extend my warm welcome to all of you for this 8th National Workshop on Implementation of MPOWER Policy in India. In the last decade, tobacco control efforts have advanced globally as well as in India. In order to mitigate the impact of tobacco use on premature death and morbidity, World Health Organization presented MPOWER, a policy package comprising evidence-based policies and proven strategies for tobacco control. These workshops provide a platform to understand the key principles of MPOWER, share good practices on MPOWER strategies implementation, and also understand status of implementation of MPOWER strategies at national and state level in India. Ladies and gentlemen, proceeding now with the formal inauguration session, please allow me to welcome Dr. Rana Jaising to state the introduction and objective of the workshop. I would also like to take this opportunity to introduce Dr. Rana Jaising. Dr. Rana Jaising is a Deputy Regional Director, Tobacco and NCD Control of the Union Southeast Asia Office. He is leading Tobacco and NCD Control Program of the Union Southeast Asia region. He has over 25 years of experience in public health at subnational, national, and international level. As a medical doctor, he has specialized training in managing chest diseases and promoting lung health. He is a master trainer for mid and senior level managers. You're most welcome, sir. Please address the audience.
Thank you, Renu. So good morning, all of you. And once again, on behalf of Union, International Union Against Tuberculosis and Lung Disease, I am pleased to welcome all of you. And I would request Liji to share my presentation. Liji. Thank you.
Hi,
Yes.
hi, Dr. Rana. Dr. Rana.
Yes, yes.
Dr. Swasti is here, and he is.
Yes, I have seen him. Yes.
Yeah, so I think we should allow him to address our participants, and then we can proceed with the agenda as such.
Yes.
Yeah,
So
thank you.
Thank you very much. So how we should do, just to update everyone that Dr. Swasti Charan, who is Additional Deputy Director General of Ministry of Health and Family Welfare. Right now he is on duty travel to state of Manipur for COVID control. Dr. Swasti, should I just say some welcome and then over to you? Is it fine, sir?
Yes, Dr. Anna, it's fine. But my only worry is some delegation is supposed to meet the central team here. They would be here any moment, so I will have to go. That is the only.
Okay. So yes. So over to you, sir. Over to you. Thank you very much for joining. And thanks in this very busy schedule, you have been able to make it for this workshop. Thank you very much. Over to you.
Thank you, Dr. Rana, and good morning to all of you. We are meeting virtually. It was always nice to meet physically, and over the cup of tea during the breaks. We would share so many things which we do not usually have time to share during the formal session. But somehow the situation is not allowing us to do that. So, but in order to work on the other side of the situation, which is COVID, I have been tasked by the Government of India to lead a central team here, along with a joint secretary who is the nodal officer for the state of Manipur. So Manipur has been showing increasing rise of cases, and we have been asked to see what are the measures which the state government needs to undertake. So we are here for the last 2 days now. We will be continuing till 2nd of November, and we'll be trying to see all the measures that we are going to take up for the state of Manipur. Having said that, for tobacco control as well, the vulnerable population which the COVID is unfortunately killing are those people with risk factors, those people with the comorbid conditions. So one of the risk factors which unfortunately is tobacco and alcohol. So this important meeting of MPOWER which we are having today is very, very relevant, in the sense that if you want to do set out taking care of tobacco control in one particular area, you need to be guided properly, which are the directions, which are the areas of priority. So it's a very large field. It is a field beyond health. It's a field beyond one government. So we need to do it in a very proper way. But to start with, we start with MPOWER, the strategy which WHO has time tested in many areas. That is why this important meeting we have here today is on MPOWER. And as far as the International Union of Tuberculosis and Lung Diseases are concerned, this is a very old organization which Dr. Rana will tell us in brief, in detail later on. But I would say that this is an organization which is really, really practical, very focused, and very led by very technically very sound people like Dr. Rana, Amit, then and Pranay, and many others who are working in that area. So I hope during the course of the day we learn a lot from each other. We try to help each other control tobacco in the areas where we are working. And as is the motto of pandemic, we should not leave anybody behind. So for tobacco control as well, we should not leave anybody behind. We should be able to offer them access to tobacco cessation. I see Mira Agi, Madam is here. Mira Agiji will be, talking in that area, which we see is of an institutional memory. Dr. Prakash Gupta sir and many other from the civil society. I see Deepak Mishra also, and state nodal officers like Gopal Chauhan, and all of you are here. So I would have loved to stay to interact with all of you, and also present the ministry's view, but unfortunately this program had come up in between after I had said yes to the union. Somehow I would not be able to do that. My schedule today takes me to a briefing meeting with the principal secretary later at 10:30, and after that we have to visit some of the COVID care centers and district hospitals in other districts beyond Imphal. So I would be on the move, and I don't think it would be justice to jump out from there, try to join here, and jump out from here and try to join the other team. So apart from this address, I would not be able to join today, and some other time I would try to join and share with you all the expectations, all the experiences, all the technical knowledge which the ministry also holds, and interact with each one of you, so that we also imbibe all the knowledge and the experience all of you have in your different fields. So with these few words, I would like to say bye for the day and wish you all the success for the remaining part of the webinar. Thank you, and sorry that I had to barge in, Dr. Rana. Thank you so much.
No, it's fine. Thank you, sir. Thank you very much. Thanks for your presence and your remarks. I think the way we have seen you providing leadership to National Tobacco Control Program in the country, that is very, very encouraging for all of us, and that is why we always expect you to be at all the events wherever it is possible. But we understand currently while you are in Manipur and having many meetings already organized. So thank you once again. And we will definitely submit a brief report of this workshop along with the recommendation for your ready reference and maybe any actions which may be required from your side. So thank you once again. Thank you. So
Dr. Swasti, Jharkhand Health Secretary sir has also joined. Nitin sir, you can see him on the screen.
HT Health Department.
Thank you, sir. Thank you for joining in. I have to apologize for not being able to stay with you longer. I will try to join again in another webinar again. Sir. Thank you so much.
Thank you, Dr. Swasti. So as you know, Dr. Swasti Charan is additional Deputy Director General, Ministry of Health and Family Welfare, and providing leadership to many programs, including National Tobacco Control Program, National Oral Health Program, non-communicable diseases, and many other responsibilities which he having. And definitely currently COVID-19 going to different states on behalf of ministry. So last month he was in Maharashtra, then in UP, today he is in Manipur. So thank you, sir. Thank you once again. So we continue with our program. So Liji, please share my slides. So thank you. So you can see 8th National Workshop on this very, very important strategy. And it's we did not want to miss it. So it is virtual in the current situation of COVID. So once again, I am pleased to welcome all the dignitaries in the opening session, Dr. Meeraji, Dr. PC Gupta ji, Dr. Gupta, Rajasthan, Dr. Gupta, Punjab, and our chief guest for today, Dr. Kulkarni, who is Principal Secretary Health, Government of Jharkhand. So welcome once again to all of you. Once again, welcome to all the participants in this workshop, all the presenters, all the faculty members, and all the staff which is providing technical and IT support for this workshop. And in fact, we have learned a new normal of organizing all these kinds of programs. We have 2 Empower workshop this year. So this is first one. This has been delayed because of this situation. And before I actually start, because in this meeting, I will like to update you that many participants, almost more than 70 participants, they are new. So it is very important, and it is imperative on my part also, just to share with you. After all, you have come on our invitation. What is Union? So Union is perhaps world's oldest public health organization, and it has its vision of health solution for the poor. You see, please see the history. 1867, when first international TB meeting was organized, when we were also not aware of how TB is caused, what is its treatment, no drug was available, there was no clear-cut knowledge about signs and symptoms of the disease. 1867, and TB germ, which causes TB, tuberculosis disease, that was discovered in 1882. That was also not known at that time. So first permanent office Union established in 1902, and the current name of Union, International Union Against Tuberculosis, that was coined way back in 1920. So it was established in Paris. So we have many members. So currently we have 14 offices worldwide. we have 5 scientific departments, which is tuberculosis, tobacco control, HIV research, lung health, and non-communicable diseases. And we have many constituent members, organization members, and individuals members globally. Next, please. So it is almost today, now it is 2020. So we are already celebrating 100 years of collaboration and innovation. In the beginning, Union had been a very, very important research organization. So a lot of research and many innovations that was part of the Union's work. But later on, when there were requests from across the globe for implementation support, so Union also started supporting, and currently Union is supporting almost 100 countries of the world in these programs which you have seen: tuberculosis, HIV/AIDS, TB, HIV, NCD control, and tobacco control. Next, please. So you can see the map, the huge presence of the Union worldwide. We have a mission. It brings innovation, expertise, solution, and support to address health challenges in low and middle income countries with a broader vision of health solution for the poor. Next, please. So this is our office. So in Delhi, in India, we have a Union Southeast Asia office, which looks after countries in our region. And providing those sport, technical sport, then sport for capacity building, training, monitoring, and evaluation of various programs in our region. Next, please. So recently, we also had Union's World Lung Conference. So this was organized in Hyderabad, and Honorable Vice President of India, Health Minister of Union, Health Minister, Governor of Telangana, Health Minister of Telangana. So they were all present, and this conference was attended by 4,700 people from more than 130 countries. So this was a very big conference which was held in India, and in India this conference was held almost after 64 years. This conference came to India. We have 4 functional areas where we are providing technical assistance, training and education, operation research, and we have many special projects across the country and across the region. We are working mainly in tuberculosis, tobacco control, operation research, and many other special projects and NCD control. In tobacco control, we are supporting almost 500 districts in 26 states with overall population outreach of 700 million people. Next, please. So I would like to little bit share with you our work on tobacco control. So Union started working in tobacco control way back when it was not very considered as a huge public health epidemic, and it was in 1973 when we first started working on this important public health menace. And currently our lot of work is happening under Bloomberg initiative to reduce tobacco use, where we have many other partners like CTFK, Campaign for Tobacco Free Kids, CDC, Center for Disease Control, John Hopkins University, World Health Organization, Vital Strategies, and the Union. So under this initiative, we are supporting tobacco control across the globe. Next, please. So if you see, I have already shared that currently we are supporting almost every state in the country, directly or indirectly, and with direct support to more than 500 districts for implementing various tobacco control strategies. We are also providing financial support under Bloomberg Initiative Grants Program. And just to update you that till date, please see the last bullet point. We have completed 53 grants, out of which 14 grants are to government Ministry of Health, Government of Delhi, Government of Tamil Nadu, Gujarat, Mizoram, Karnataka, Jammu and Kashmir, and Chhattisgarh. In addition to that, we have many NGO grants. So roughly we have completed almost 39 NGO grants till date. So currently we have 18 active grants also. Next, please. So I would just like to share with you that till date, Even since 2007-8 almost 500,000 5 लाख लोग अभी तक लोगों को ट्रेनिंग दिया जा चुका है under tobacco control program, and many very senior level officials, almost roughly 2,000 senior and intermediate level officials, they have been trained for tobacco control initiative and including international management development program. And many of you have also attended almost these programs, including anti-CP trainings and capacity building across the country, which we have been doing in collaboration with our other partners, mainly World Health Organization, WHO country office. So in their collaboration, we are doing many such trainings. So now about this workshop. So it is a 3 days workshop we have planned, and what are its main objectives? Why this workshop? So for that, we also need to understand how it all started. So it was the point where we got WHO FCTC, Framework Convention on Tobacco Control and MPOWER. They provide the foundation for countries to implement and manage tobacco control. And to help make this a reality, a simpler version of broader FCTC, Framework Convention on Tobacco Control, is MPOWER, for which we are all here. So here in this workshop, we will learn what is MPOWER. So it's a set of guidelines for controlling the demand and supply of tobacco. Next, please. So at the same time, because this is opening session, there are many other guests. So we also need to understand why tobacco control, why we are doing this, how it is done. It is very important to understand how it is done. What are the strategies for tobacco control? By whom? Whose responsibility? Who is responsible for all this work? And what is the current status in India? And I hope that in these 3 days, we will be able to very, very clearly convey this message. India is the largest consumer of tobacco. It's a major public health challenge globally and in India too. Common risk factor for NCD. After independence, communicable diseases was our major burden, but the burden has already shifted to non-communicable diseases. Now, roughly, if we combined all NCD and other factors like motor vehicle and road accident deaths, so roughly 67% burden is now non-communicable diseases, where tobacco is a common risk factor. It's a development issue. Tobacco leads to many social, development, and economic risk for our countries, for our society, and it's an important cause of poverty also. And please see the highlighted portion. It is entirely preventable epidemic. It's very, very possible. Sometimes there are a few things which are not in our hand, but this is entirely preventable epidemic, and the governments has to act upon that. And it is now also our obligation, because India has signed FCTC, so it is our obligation that we effectively implement tobacco control in our countries. Next, please. So please continue. Next, please. Yes, please. Next, please. It's fine. So tobacco, you are aware, it causes death and disease. All forms of tobacco in any quantity are harmful. People often say BD is less harmful. People often say smokeless tobacco is less harmful. But every kind of tobacco in any quantity, it is again very important. People often ask, even one cigarette is harmful? Yes, even one cigarette is harmful. Even little exposure to second-hand smoke exposure is harmful, and it causes premature death in children and adults. Next, please. So this is our now final, that why we are here, how tobacco control is done. People often say, let's make people aware of harms of tobacco. Whether that is sufficient by making people aware of harms of tobacco and about the policies, or something more need to be done. So this is our strategy for tobacco control, which is evidence-based strategy, and we need to see that it is effectively implemented across the country. It encourages policymakers along with the rest of the society, including civil society, healthcare providers, and others, to envision a world which is free of tobacco. Next, please. Next, please. So who is responsible? As I already said, perhaps tobacco is one issue which is where no one can say, no one no segment of society can say that I am not involved in this. Everyone is a stakeholder in tobacco. All ministries and government departments, either they are involved directly or indirectly. Civil societies, public health institutions, individuals. So that is why everyone is involved. And often, because I am from public health side, so people often say, is it a public health problem? So keeping in view, there are so many dynamics involved in tobacco control. People, our colleagues often refer it as it's not a public health problem, it is a political problem. So we need to see that how our policymakers, highest level of administration, they take those strong steps for its effective tobacco control department, and not only its responsibility of health department alone. So we wish that in this workshop we will examine the key principles of MPOWER. What is MPOWER? What's the importance of each of these segments? We will also share with you, our faculty will also share with you some national and international best practices on MPOWER strategy. We will also try to understand level of implementation of MPOWER at national and state level. And then we will see that our participants in this workshop, they establish a system of monitoring and evaluation of tobacco control activities. So this is the objectives of this workshop. And finally, we expect that we will have broader understanding about the various strategies. We will learn from this demand side strategies, supply side strategies for effective tobacco control. And then we can also develop a framework for adequate implementation of MPOWER package at state and district level. Next, please. So thank you. We have a long way to go. After this workshop, we will also discuss with you the progress which has been made in the country in last 1 decade, or maybe more than 1 decade, 1.5 decade of our work in the country, and all our faculty and participants will share that. So once again, thank you for your presence. And I would also request you, all of you, to please share your video so that everyone can see. So over to Renu. Thank you very much.
Okay, thank you, sir, for stating the union's work and the importance of this event. So now moving forward, it is now my pleasure to introduce our next guest of honor, Dr. Meera Biagi. So Dr. Meera Biagi is a behavioral scientist and a communication expert working in tobacco control internationally. She is PhD in psychology from Loyola University of Chicago, USA in 1969. She is affiliated to Healy Sikh Sharia Institute of Public Health, and she is the chair of the Union Scientific Section of Tobacco Control, and she served other international organizations also like International Development Research Center, CARE International, WHO, and UNDP. She is the recipient of the WHO Gold Medal on Tobacco Control in 1989, tribute for outstanding service to women from International Network of Women Against Tobacco in 2009, and the Luther Terry Award for the Tobacco Control in 2012 in Singapore. So you're most welcome, ma'am. Please address the audience.
Hello, Meera ma'am. We are not able to hear you.
Sorry. Good morning. Good morning. I'm very happy to be here. Dr. Rana has really enunciated the introduction of this topic very well. However, I will say a few words since Renu does want me to say a few words on this topic. We all agree that those working in tobacco control want the present and the future generations to be urgently protected from the devastating health, social, environmental, and economic consequences of tobacco consumption and exposure to tobacco smoke. We are fortunate that MPOWER has been conceived as a policy tool package intended to assist in the country level implementation of effective interventions to reduce the demand for tobacco. It basically tells us how well the program is working and to what extent the program is being implemented in the country. Governments around the world that have ratified the Framework Convention are encouraged to make legislation to help to achieve tobacco control. Not only that, these governments are motivated to use MPOWER to monitor and watch the implementation of the policies which have been made, which have been deduced from FCTC. Such evaluation help us to map the position of the countries as far as if the implementation of policy is concerned on the global map. So this is just about what I intend to say for this introduction. Thank you very much for inviting me, Renu. Back to you, Renu.
Okay, thank you, ma'am, for the wonderful address. Okay, now, ladies and gentlemen, it is an honor to welcome our next guest of honor, Miss Vineet Gill Monish. So, Miss Vineet is a National Professional Officer at the World Health Organization Country Office, New Delhi. She is a seasoned management professional with 25 years of experience in marketing, public health, and development sector. She worked extensively in the UN and private sector and developed unique proficiency in strategic planning, health policy, program management, policy research communication, and resource mobilization. Adapted leading cross-functional teams, building partnership, and establishing constructive relationship with the key stakeholders, including national and subnational level governments, philanthropies, donors, UN agencies, civil societies, and academia. So you're most welcome, ma'am. Please address the audience.
Yeah, good morning, everyone. It's indeed a pleasure to be here today, and I'm very grateful to the union for organizing this webinar today, this training today and tomorrow. And I think, it's as Dr. Rana shared earlier, this new normal is emerging as a very beautiful way of connecting with all of you. I'm currently based in Singapore because of the whole lockdown. I've been teleworking from here. And as Renu just shared, I work with the World Health Organization India office, been there for almost 20 years, and very happy to be here with you all today. You see, when I think about MPOWER and why we are all here together, my thoughts go back to 2001 when I joined WHO, and the WHO Framework Convention for Tobacco Control, which of course, from where the MPOWER strategy emerged, was under development at that time. And our dear senior colleagues, Dr. Aghi and Dr. P.C. Gupta, were very much part of that process. And I was very honored to be part of that process too. And it was actually as early as 2001, 2002, when India took the leadership, and was actually the regional coordinator for our region, the Southeast Asia region, to go forward with the development of the FCTC draft, which was being discussed by the 192 member states under the aegis of the World Health Organization. The WHO FCTC is one of the first and foremost public health treaties, which was developed under the aegis of the World Health Organization, and it is also one of the fastest adopted treaties. So many of you are new here and are new to tobacco control. So just to give you a background of the very important journey and heritage that you are a part of today. And so obviously tobacco control is a very, very important area of work for WHO and has been for the last, a very focus for the last 2 decades. Since the WHO FCTC was developed in 2003, India was one of the first 7 countries to actually ratify the WHO FCTC. After that, it has been very, very beautiful, a roller coaster of a journey, because tobacco control is not easy. It brings you very few highs and many, many lows, because it's like trudging up a very high mountain where you are constantly you'll come across many, many, blocks and whatever, but we have managed to walk that path with the strength of this entire community, which is so determined to save needless loss of lives from tobacco control. And after the FCTC was ratified, in fact, we soon came to a stage where, the government of India felt that it was very important to have a national tobacco control program, because while policies were being drafted, but there was no dedicated resources to take these policies forward, especially at subnational level, where the actual implementation had to happen. So WHO was again very fortunate to assist the government of India in development of the first seeds of the National Tobacco Control Program back in 2006. After that, this program received a lot of support with the Bloomberg Philanthropies investing in global tobacco control, and all partners becoming more committed to tobacco control and supporting it. The union has been supporting hundreds and hundreds of trainings across in the last 15 years and have developed this base so beautifully. So with the coming of the National Tobacco Control Program came in all the states and all the action that has been happening. So all of you who are working at state level, both within the government and with non-state actors, that is civil society, you are the actual doers. You are the ones who are actually going to make the difference happen. So, which is why this training today is very, very crucial, and I would say very, very important for all of you as you go forward. Coming to Empower, of course, I'll be speaking, sharing with you a presentation on Empower later in the technical session. But, when we develop a very large framework, sometimes it's not possible to implement everything in every country. So that is when all partners got together and said, what are the 6 main strategies which would work if we truly want to implement tobacco control in countries, in member states of all kinds? Every member state has their unique strengths and weaknesses. And what are those 6 things that work? And that's where Empower was christened and developed and, put out as a package for all of you. So it's like this, it's like when we used to have exams, we had the little kunji, the little key book, and this is what Empower is today. It's easy to implement, understand, and go forward. India has implemented many, many policies which have made it a global leader actually. There are certain policies like, tobacco-free films, no sale around educational institutions, where India has gone beyond the FCTC and rather informed the FCTC and other member states about policies which work and actually has put down models, working models for the rest of the world to follow. So with that, India also, in fact, hosted the Conference of Parties of the WHO FCTC in 2016, where all member states came down to India, and the government of India hosted that event. So just to sum up, India has been in a key leadership position for tobacco control over the last 2 decades or so. And we are all very honored to be part of that process. And going forward, we need more, the baton needs to be passed on to more people to get these policies down to the ground level. And I hope that this workshop today will assist in doing that. I would also like to convey my thanks to and honor to participate along with the chief guest for today, Dr. Nitin Kulkarni, Principal Health Secretary, Dr. Gupta, Dr. Agi, and the entire team from the union, Dr. Rana, Pranay, Amit, Renu, Shami, all of them who worked very hard to put this together. And of course, all of you out there, many of our colleagues who have worked in tobacco control for many years, and more importantly, the ones who are just starting out. Wishing you more power to your journey. Thank you so much.
Thank you, ma'am, for sharing the valuable vision with us on WHFCTC and Empower. Thank you so much, ma'am. So now moving forward, I would like to invite our guest of honor, Dr. Prakash Gupta, to address the participant. It is an honor to introduce Dr. Prakash Gupta. Dr. Prakash Gupta is a director, Healy Sikh Sharia Institute of Public Health, Mumbai, and a visiting scientist at the Howard T.C. Chan School of Public Health, Boston, an adjunct professor of epidemiology and biostatistics at the Arnold School of Public Health, University of South Carolina, USA. He has received several awards, including Luther Terry Award from the American Cancer Society in August 2003, and Tobacco Free World Award from the Director General, World Health Organization, Geneva. He is a mentor to us in tobacco control fraternity. So we welcome you, sir. Please address the audience.
Thank you very much, Renu, for this very generous introduction. First of all, congratulations to Union for organizing this very important meeting on Empower for advancing tobacco control, for understanding tobacco control and the situation of tobacco control Empower strategies in India. So that's, and I'm honored and I'm very happy to be a part of this particular meeting. And I have, of course, I recognize all my long-standing friends and colleagues in tobacco control and value their advice, their help in advancing, in thinking and strategizing tobacco control in India, including everything in FCTC and in Empower strategy. So I think about Empower, how it came about has already been described very clearly by Vineet, and the situation on tobacco control, very excellent introduction by Dr. Rana Singh. Dr. Rana Singh said that some of the participants who are here may really be attending tobacco control or hearing about it in very early stage, for the first time or in very early stage.
Yeah.
So for these people, for such persons, my advice and caution would be that there are huge number of misconceptions that are there already in the society about tobacco and tobacco control. So if anyone is starting in tobacco control, it is extremely important that you equip yourself with the knowledge of the about those misconceptions and how to address them as on scientific basis, because these are misconceptions and we don't have to counter them with our beliefs. They are to be countered on scientific basis. There are many, many, many examples. This is not really time to go through all of them, but for example, in India, one argument often comes up that tobacco is very old, it's ancient. And why you are talking about it now? It is here for a long time, it is there in Ayurveda, and all such arguments are there many times. So you have to say that tobacco is not very old as far as India is concerned. It was discovered by 500 years back when America, New World was discovered. It came to India 400 years back, and it has become popular only during that period. And the public health effects are now visible, and that is how we have to take very strict measures on tobacco control. So in the same way, there are many, many misconceptions that are there, and there are very good scientific responses to such misconceptions. Now, for those who are already in tobacco control, you know about MPOWER, and we also know, like we heard from Vineet, that India has been a leader, has implemented all the MPOWER strategies. And of course, when we evaluate, we look at that. Each strategy, they are not equal, of course. Some are implemented much better than others. Some still more work is required. And that is the kind of deliberation I'm sure that will keep on going in the rest of the workshop. I have been a research scientist. I'm basically a researcher. So I would say more about research basis and how our research is helping to further advance the ideas and strategies in MPOWER. Just give you a very small example. In the recently concluded curtain raiser for National Conference on Tobacco or Health, there was a session that Dr. Rana was very kindly co-chairing. And in that session, we kind of learned that tobacco vendors, not only the placement, we know that placement of tobacco vendor is very important. And that's why in our act, tobacco vendors should not be there within 100 yards of any educational institution. But the research also shows that density of tobacco vendors is extremely important. And that is why we now know, we all know that tobacco vendor licensing is an important part of overall tobacco control strategy. And some of our states, I think Jharkhand Principal Secretary is here, and we know that they have been able to successfully introduce that kind of strategy. In the same way, something new, as a science, we sort of keep away from religion. And that is fine. Religion appeals on a different note, and science appeals on a different note. But what we learned that the religiosity or a person when he prays, that also affects his intention to use tobacco and future tobacco use. So that is also a very important strategy or thinking that we should keep in mind while thinking about tobacco control. So I won't take much time now, and we have a lot to go. So I will stop here, just emphasize that we have to keep all the aspects in mind, including the research aspect for furthering and advancing MPOWER strategies and tobacco control. Thank you very much, Rana, Dr. Rana, and Renu, back to you.
Okay, thank you very much, sir, for the remarkable speech. So now moving right along, I have a privilege to invite our chief guest, Dr. Nitin Madan Kulkarni, IAS, Principal Secretary of Health, Government of Jharkhand. So Dr. Nitin Kulkarni is an MBBS doctor. He is a gold medalist, and he is an IAS officer of 1995 batch of Jharkhand cadre. He is presently posted as Principal Secretary, Department of Health and Medical Education, Government of Jharkhand. Prior to this position, he has served as Secretary of Urban Development and Agriculture Department in the state. He has also served as a Deputy Commissioner in various districts of Jharkhand, include East Singhbhum, Bokaro, and Dhanbad. Since Dr. Kulkarni himself is a medical doctor, he understands very well the severity of tobacco use and necessity for tobacco control. Under his able guidance and leadership, Jharkhand has taken many initiatives for tobacco control. During the COVID-19 period, he had banned the sale and use of all tobacco products, including smoking and smokeless tobacco in Jharkhand. He has He has also issued order for statewide ban on spitting. As a Food Safety Commissioner of Jharkhand, Dr. Kulkarni has issued order to ban 11 brands of adulterated pan masala in the state. So now may I request sir to kindly enlighten us on the initiatives taken by Government of Jharkhand and also provide the valuable suggestion for the participant of this Empower workshop. You most welcome, sir.
I am audible and visible.
Yes,
Yes, sir, loud and clear.
Thank you. So good morning and thank you Renuji for such a nice introduction. Nowadays you don't get in the era of webinars, you don't get such a long introduction of speakers. They just ask someone to start and the speaker starts. Dr. Rana, Dr. PC Gupta, Dr. Meena Aghi, Ms. Vinita Gil Munish, and Mr. Pranay Lal and Mr. Amit Kumar. It's really a pleasure to be a part of this conference today, and I welcome all of you and extend my sincere good morning wishes, and I hope that we are meeting in a pandemic era. In normal courses, we should have been sitting in a cozy environments of some 5-star hotel or a big banquet hall, and now you are sitting here and interacting each other through a virtual mode. I'm happy that the union has organized this special workshop on implementation of MPOWER policies in India. And I sincerely thank Dr. Rana and his entire team for taking up this important initiative. All the participants who have joined, I really appreciate your effort that you are ready to offer your time for this noble cause. When we talk of health, a common discussion point is the out-of-pocket health expenditure and what we call as a catastrophic health expenditure, and this is supposed to be the sort of breakneck situation for many poor families. It is said that economies of the family get wrecked by a single catastrophic health expenditure, and unfortunate part of this health expenditure is most of it, almost more than 60-70% comes from avoidable diseases or preventable diseases, what we call as NCDs, which are dependent on your lifestyle. And tobacco use obviously is a single large preventable cause of deaths as far as this portion is concerned. The data says that about 54 lakhs people get globally suffer because of this tobacco, and India accounts for almost 25% of them. And unfortunately or fortunately, Jharkhand accounts for about 39% of tobacco consumption in the country. So as per that GATS 2 survey. Now the problem of tobacco, we have to see it one in a perspective of smoked tobacco and smokeless tobacco. When we say tobacco, immediate concentration and immediate focus goes to the smoking part of it, cigarettes and associated issues. But what is causing more damage is the smokeless tobacco components, and which almost go unnoticed in many parts of the country. So we need to ensure that our tobacco control laws, which has some social provisions, some penal provisions, but we are trying to implement all those laws in this letter and spirit actually. And so as rightly said by Dr. Rana also, tobacco control is a multi-stakeholder issue, and it requires participation, cooperation, coordination of not only health department. It's not a health issue, it's actually a sociological issue. So we require a participation and coordination of all the departments of the government, because everybody is a stakeholder in this game. I'm happy to inform you that in the state of Jharkhand, tobacco control programs are being implemented rigorously, at least since last 3-4 years. And we have a development partner in the form of seeds, and we always get a great technical support from the union or Southeast Asia office. We have completely developed institutional structure in the form of a state tobacco control cell. There is a state tobacco control coordination committee headed by the chief secretary, and there are squads at the state level. There is a district coordination committees and district level squads, and these keep on doing the rounds and taking necessary measures for as far as the penal part of is concerned. As Dr. Gupta was just now mentioning, our Jharkhand has a municipal act, and in my earlier posting, I was the person who was associated with drafting this act. We have a clear provision for giving a vendor license even for tobacco. So if you have to have a tobacco shop, you have to have a vendor license. And right now we have implemented it quite effectively in the urban areas of Ranchi. And we are now scaling it up to all the municipal areas at least, because this municipal act applies to all the municipal bodies. So we are applying this act to throughout the state. So that will be a sort of some control, or we'll have at least a sort of say licensees who will be selling the tobacco products. I think this vendor licensing system should be made mandatory not only for states but at the national level also, so that it's a uniform system throughout the country and there is no such feeling like we are being asked to do some extra. I think by deterrent policies, and there are obviously penal provisions also for under COTPA and many other similar provisions. But most important concern, this I am telling as a medical professional, most important concern about tobacco consumption, that it is a behavior, and it requires some behavioral intervention and behavioral change, and more than behavior, because it gives you a sort of a kick or a momentary pleasure sensations. Nothing more than that happens actually. But over a period of time, this behavior gets converted into a habit, and to break a habit, you at least have to have two very clear motives. One, this habit, habitual behavior or whatever you are doing, it should not be an attractive thing for me to do. And number two, it should not be an easily accessible thing. So if we think about making it inaccessible to as extent as possible, and secondly, making it unattractive, like some drugs, after you smoke and then you take some drug and you develop some reaction, so it becomes unattractive too. So right now what is happening, the marketing of these tobacco products is being done in under different names. In fact, I personally don't understand still what is the difference between gutka, pan masala, mouth freshness. Everyone just keeps on a sort of a surrogate advertisement and the products are more or less same. So regulatory authorities get constrained because of certain, like you do some action against someone and immediately it will be challenged by the people that we are not gutka, we are a mouth freshener. And then it becomes very difficult to defend it in the court of law. So I think there is a very strong need to clearly demarcate these products, whatever name you name them, but clarity has to be there that what is a tobacco containing product, whatever name or whatever genre you put it in, but it has to be a tobacco product. Smokeless tobacco also, same thing. We have already banned our smokeless cigarettes, and hookah bars also we are in the process of banning. But most important part, the eastern, particularly I am talking about the eastern India part of it, like Bihar, Bengal, Orissa and Jharkhand and some northeastern states also, is the consumption of this smokeless tobacco products like khaini. Now khaini is a very raw tobacco, named as a very different names. They called it surti, tambaku, or gul also, which is used for cleaning the teeth actually, but it gives you a sort of a complete feel of a nicotine. So these are neither taxed, neither they are regulated. They are just sold in open market. You can go to any weekly hut and you can get access to these things, and people don't feel that there is anything wrong in eating it. I think that point was very valid. When you require intervention, you have to involve all parts and all sections of the society, because if a religious leader or if a priest sitting in a temple tells a person to do certain things, chances of compliance definitely increase. So it is very necessary as a part of a regulatory framework to bring all these smokeless products which are currently unregulated to bring under the regulation, and their sale and their production in fact needs to be. But there is an issue I have seen in agriculture department also. There are many farmers whose survival depends on this farming of tobacco products. So that also we need to consider what is the alternate means of employment, or what is the alternate use of those things which should not come into the market for this particular purpose. Finally, obviously a tobacco-free society is a goal for all, and I think if you can create a tobacco-free society, I think it will be adding to the economic development of the country as a whole. Because if you look at it, people always talk in the terms of revenue. Governments, as a government officer, I am supposed to be bothered about the revenue collection part of also, and that is a justification given for allowing certain tobacco products, that they generate a lot of revenue for the government. But I think the same justification goes for the excise products like liquor. And there are a number of states where liquor is banned for, like Bihar and Gujarat. And I don't think their economy has suffered, or Gujarat is known as the most developed state in the country today. They are having prohibition for so many years. So revenue cannot be a justification, because if you consider the health expenditure in the name of, because of this tobacco related issues, I think that overshadows the actual revenue collection part of it. So I hope that the discussion goes along. I can see a long list of topics, and you have a theme-based discussion. So I wish all the best to the conference, and we need to, obviously we are looking forward for some good suggestions and some good policy interventions which will actually realize the dream of a tobacco-free society in real sense. Right now, tobacco-free society, most of the cases it is on paper, and we have to actually enforce it. But if it comes from within, that there is no demand in the market, I think that market will automatically be over. So we have to move to the situation where we have to just ensure that there is no demand left for this product, and that is only possible through our continuous interventions and behavioral practices. So I wish all the best to this conference, and I hope that the union and our development partner seats will continue to support us. And I can promise you that we are committed to this goal of tobacco-free Jharkhand, and we are pursuing it, and we will pursue it to the last. Thank you very much. It's my pleasure to be here. Thank you.
Okay, thank you, sir. Thank you very much for sharing your vision on tobacco control and the valuable remarks to the participant. Thank you once again. So now I would like to request Dr. Amit Yadav, Senior Technical Advisor of the Union, to give vote of thanks to all the distinguished guests. Over to you, Dr. Amit Yadav.
Thank you, Ms. Renu. I think we can now unshare the screen so that we can see all the people. And before I propose my vote of thanks, I'll also request everyone on the to open your cameras for 1 minute or a couple of seconds so that we can take a picture and all of us can be on one screen, please. Sami, please take pictures. I can see Liji, Deepak ji, Dr. Vishal Thakur, Sami. They are on my first screen but not visible. So if more people should open the camera so that we can see them on the first screen. Thank you so much. Thank you. I'm taking pictures, and I'll ask Sami also to do that so that we have all the screens covered. And yeah, thank you, Ms. Renu, and thank you, everyone. It's a pleasure to propose this vote of thanks, and it's been a lot of efforts for last couple of months and trying to, in terms of discussing how will we do that. This has been our, in terms of most important workshop that we do every year, and it's the 8th workshop on Empower. And Empower, as I think all the stalwarts are here, and they already highlighted how important is it in terms of to talk about Empower. That's the most important tobacco control strategy to reduce demand. And I'm first and foremost, I'd like to thank Dr. Nitin Madan Kulkarni, sir. In spite of his busy schedule, and it's a Corona period where all the officials, especially health officials, are very busy. We saw Dr. Swasti was very busy, and in spite of that, he made time for us and gave his, in terms of his vision and his work that he's already been doing in different field, and highlighted that how it is important to work on a multi-stakeholder approach when we talk about tobacco control. Thank you, sir, and we look forward to Jharkhand, one of our model states of tobacco control. It's already there, and a lot of work is going there. We are happy to provide all the technical support required. I also like to thank additional DDG, Dr. Swasti Charan. He's not now present, but I think you see his commitment that in spite of him being there as in terms of someone who is there to monitor and look at the COVID situation, but he took that 5 minutes and spoke to us. So that's his commitment to tobacco control. We are grateful to him. Dr. Gupta, he is a mentor to all of us on this screen. We have learned tobacco control from him. Dr. Vineet, we started tobacco control, like I started tobacco control in 2007 and started closely working with WHO since then. And she has been leading the tobacco control efforts in WHO in India office. And she is in Singapore, but she joined and very grateful to her. Dr. Meera Aghi, again, another very dedicated person and a mentor to all of us. She has joined from California. She is there, and in spite of her time, it is already 11 there, and she has joined. So thank you very much, ma'am. I'll also like to thank all the participants for making time in this virtual and COVID period to join us. Dr. Rakesh Gupta from Rajasthan is here, and he is another champion and WHO awardee. He works a lot on tobacco cessation. He's here with us. Dr. Rakesh Mahajan from Punjab. He has led tobacco control efforts in Punjab, and he has joined us. Deepak Mishra ji, he is a champion from Bihar and Jharkhand. He has changed the scenario, tobacco control and tobacco use scenario in these two states. So very grateful to him for joining us. Dr. Dhirendra Sinha, he has also joined, and he has worked his life as surgeon and then at WHO. He has been technical advisor for Southeast Asia region. And thank you, sir, for joining this inaugural session. And we will hear more when participants hear from him on monitoring and interact with him as an expert. So thank you, sir, for joining us. Dr. Sonu Goel, Professor Dr. Sonu Goel, he has also joined us, and he's leading our RCTC. This inaugural session is being telecasted live on our resource center, which is run by Dr. Sonu. We are grateful to him for providing that support as well. Thank you, sir. We are also joined by Mr. Ashish Pandey from our New York office. So thank you, Ashish ji, for joining this session. And it's late night there, but you have made time and joined us. Thank you so much. And I'd also like to thank all the participants here and also who are watching on YouTube live. So thank you for joining us. And finally, I would like to thank the whole union team who has made this possible. Pranashar, Dr. Nidhi, Mr. Govind, Shivam, Dr. Shivam, Ms. Renu, Liji, Sami, Sonia ji from finance, Deepak and Gopal for IT support. So thank you everyone, and I know it's a pleasure, and we will continue next about 2.5 days, I'll say, and but virtually a couple of hours, not more than that. But thank you so much for joining, and we hope that it would be an exciting and enriching and interacting 2-3 days for us. Thank you so much. Back to Renu, please, we can move forward with the next session.
Thank you, everyone.
Thanks, everybody.
So thank you once again, Dr. Amit, for such an elaborate vote of thanks. And I would also like to extend a very heartfelt thanks to all our dignitaries, honorable guests, speakers, delegates, for making it possible to this workshop today. And I would like to once again welcome all our participants to this forum in attending the 8th National Workshop on Implementation of MPOWER Policy in India. Before we dive into our technical sessions for the day, I'll briefly put forward the structure of this workshop for our participants. So the workshop is basically spread out for a duration of 3 days. So beginning from today, we would be covering the module 1 and module 2, which covers the component M and component P of the MPOWER policy package. Tomorrow, we would be focusing day 2 on the module 3 and module 4, which is the component O and component W of the MPOWER package. And the last day, we would be covering module 5, module 6, and module 7. That is the E and R component of the MPOWER package. And we will also deliberate on some existing challenges in tobacco control, as well as some new opportunities that are available for advancing the tobacco control in India. Ladies and gentlemen, I would also like to bring forward that we have a very, very new interesting session also in the workshop, which is Meet the Expert session. This session will allow all our participants to be on one-on-one basis with our expert in the respective field. You may ask relevant questions, queries, concerns, or any thoughts that you would like to share with our experts. You can also put in the queries into your chat box, and we can take that during the Meet the Expert session. We also have other few interesting aspects of the workshop, such as the questionnaire poll, the feedback session, and the assignment session. So I would hereby request all participants to kindly be actively involved and be very involved in the workshop. So let us now start with the first technical session, which is, as also Dr. Rana previously explained and all the other stalwarts also explained, what is the need for tobacco control. To begin with, the first presentation in the introduction session, that is Need for Tobacco Control, may I please invite Dr. Rana J. Singh, Deputy Regional Director, the Union Southeast Asia, to kindly take the session on health, economic, and environmental burden of tobacco use from global as well as national perspectives. So extending a very warm welcome once again, sir. Over to you.
Yes, thank you, Dr. Nidhi. So once again, welcome to our next session, which is setting the scene. So basically, this session is just meant to inform what is the current burden, what are the current policies for tobacco control, and what is the current status of tobacco control in India. So there will be 3 presentations. So I will take you to the first part. What is tobacco burden? Its health, environmental, and socio-economic impact globally as well as in our country. So next, please. So I always show this slide about what is this. So I would like to share with you my experience of almost doing so many trainings across the country. Please show the next slide. Next slide. So you will be surprised that in most of the training, hardly 1, 2, 3 people raise their hand when we ask this. How many people have really seen this field? Even if the training is happening in a state where there is this tobacco crop is grown. So these are few pictures from state of Gujarat as well as from state of Andhra Pradesh. So the same question is to the participant of this workshop. How many of you have seen tobacco crop? Despite the fact that it is many states which are not growing, except 7 or 8 states which are mainly produce most of the tobacco, more than 90%. Many states do not produce or grow tobacco in the country. So these are few pictures that how tobacco crop looks while it is in the field. Next, please. So tobacco is a leading cause of preventable death. So very, very important for us to understand. And I always place this importance for all of us. We need to understand preventable cause. So because this is short word is very important when we start or when we deal with any public health emergency. Currently, it kills 7 million people each year, according to WHO report of 2018, which is the latest one. So about 7 million people. 7 million means 70 lakh people are killed by tobacco globally. And we will also compare it with the other disease burdens. So 1 billion people will die. 1 billion people means 100 crore people will die in this century if we do not do anything. Next, please. In poor and developing countries, it is emerging as an epidemic. Till few years back, we used to say that tobacco is not our problem. Non-communicable diseases, hypertension, cancers, they are not our problems. But it has already become an epidemic in even poor and developing countries. High public health costs for tobacco-related diseases. This we need to understand. And it kills people at the height of the productivity. And in some low and middle income countries, poor spend almost 10% of their income on tobacco. Next, please. So, as I mentioned earlier, in the last century, almost 100 million people have been killed by tobacco and leading preventable cause. And please see the red portion. It kills half of the people who use it. Do we have any other product in our society, whether it is eatable, whether it is something which we wear? So, is there any other product in our society which kills half of the people who use them? No, it is only tobacco. If today 100 people, so you can, every person representing their states in this meeting, in this workshop, you can estimate what is the current burden of what is the number of tobacco user in your state, especially the smokers. And if we do not do something, half of them will be killed because of tobacco use. Until we take urgent action, almost by 2030, 8 million, 80 lakh people will die. And mostly that burden is in developing countries. So the burden, the epidemic burden has been shifting from developed countries to developing countries. Next, please. So this is very important. I won't go into detail because keeping in view that it is a virtual conference, it is not possible to share each and every health factor with you. Simply you keep in mind those who are not medical doctors. There is no body part which is not affected by tobacco. You need not to think even. Start from head to toe. Every organ of our body is affected by tobacco use, smoking or smokeless tobacco. And you can see the picture on left side. It is someone who smokes tobacco. And every organ, so many types of cancer. Earlier, normally when we ask what kind of cancer can cause tobacco, people immediately say mouth cancer and maybe lung cancer. But please see the list. There are almost more than 15 types of different cancer, and even the now latest one, even carcinoma, cancer of breast, carcinoma of cervix, they are also related to tuberculosis. And on second picture, which is health effect caused by second-hand smoke, popularly called as passive smoking. So it's very, very important to understand that second-hand smoke exposure is also harmful. It also causes death and disease. Next, please. So I won't go into detail. So it is not something that we have come to know of harms of tobacco in just a few years before our current situation. It was way back in 1938 when first time Dr. Raymond Pearl reports that smokers do not live as long as non-smokers. Similarly, there was another study from Germany which finds strong dose response relation between smoking and tobacco, lung cancer. Similarly, there was another study which noted that there is a parallel rise in smoking and lung cancer. As the smoking increases, there is an increase in lung cancer cases. So you see, it is almost now almost going to be 100 years when we know. But even before that, there had been instances where harmful effects of tobacco use have been reported. Next, please. So again, there were many key case control studies which documented very clearly the harmful effects of tobacco, how smoking is related to lung cancers, how heavy smokers are almost 50 times more likely to get lung cancer. So there have been many such studies where it was proved beyond doubt that tobacco is harmful. Next, please. So this was another important report of the Royal College of Physicians, which again noted about the harmful consequences of smoking. Next, please. And this is the report which really paved way for tobacco control globally. It is 1964 US Surgeon General report, which on smoking and health, which clearly concluded that there was no doubt. Even today, you see, many of you might be aware of the incidences when many people said that who says tobacco is harmful. So this is the report of US Surgeon General, which clearly showed that yes, tobacco is harmful with the complete evidences they provided. And that was the turning point when people around the globe and in US, they started paying attention Two, that how we know we should start for tobacco control. Next, please. So most recent evidence, you see on left side, so many type of cancer which is caused by tobacco, and not only the lung cancer or mouth cancer, leukemia, even blood cancers, liver cancers, stomach cancer, pancreas, kidney, cervix, ureter, bladder, and many other diseases, stroke, cataract. So I think that everyone, I would request to please go through, study what are the various harmful effects of tobacco use. But keep in mind, almost every organ of our body is affected by tobacco use. Next, please. Burden is shifting. So very important, very clearly. In 2000, in developed countries, there were 2 million deaths. And developing countries, roughly there were, in developing countries. So almost in 2000, just 20 years back, the death in developed country and developing country was almost same. World total almost 4 million deaths. Now see, if we do not do, already the burden has shifted to low and middle income countries, developing country. By 2030, developed country will only have more, will increase death by 1 million, but developing country will have 7 million deaths worldwide. So burden is shifting to our countries. Next, please. And what about youth? Yes, every year, every day, almost 100,000, 1 lakh youth become regular smokers. Now we don't have much data about other aspects, but in India we always say the study, which is again almost now 20 years back, that almost 5,500 youth start to tobacco use every day. 1/5 of young people begin before they are 10 years of old. High exposure to second-hand smoke exposure. Even within our country, we will share what is the second-hand smoke exposure in the relevant session in our country. So globally, also there is high second-hand smoke exposure, and it is predicted to kill 250 million. That is 25 crore children and adults which are alive today. Next, please. So very quickly, this is a very quick slide for you just to see where is the global burden, where is the burden. So these are 10 countries where we have almost more than 80% burden is there. But every country we have tobacco use is there in every country of the world. But China, India, Indonesia, so you can see that almost 4 countries are in our region. In this Asia and Asia Pacific region. So we have China, India, Indonesia, then we have Bangladesh, we have Germany. So there are many other countries in this region where we have almost 80% burden of tobacco use. Next, please. So just to compare it, just I mentioned in my earlier discussion, we used to say earlier I worked in TB control program also, and I used to show a graph where TB burden was much higher than all other diseases. Now, just to compare it, it is an old slide, but just to compare it with all other diseases, low respiratory disease. So the burden because of tobacco is more than current 3 major killers of the global killers. One is AIDS, TB, and malaria. And even now, including road accident deaths or traffic injuries, so the burden by tobacco is more than all of these other killers globally. Next, please. And again, you can say it is a risk factor for 6 of the world's 8 leading causes of death. So tobacco is a risk factor for 8 leading causes, whether it is heart diseases, cerebrovascular diseases, lung diseases, HIV, then tuberculosis, lung trachea, and bronchus, and other lung cancers. So it's an important risk factor for all these diseases. Next, please. And now this is a slide which I want to place before you. This is a slide which is very important for ensuring and just to highlight to the policy maker. You see, first bar, it is related to AIDS. And yellow point here that shows that the burden which we have. So AIDS causes about almost you can say this many 2 million deaths, and see the funding available for AIDS control. Almost $20 billion funding is available. Similarly, please see the burden of TB, tuberculosis burden. It almost causes 1.5 million deaths, and we have roughly so much funding available. Similarly, for malaria, which causes again much less burden than tobacco, but we have some kind of satisfactory funding for malaria control. Now see the last slide, tobacco. Even you see burden, this is a burden because of tobacco. But what is the funding available? See, the red light, this bar is not coming out. Hardly any funding is available globally. Why funding is not available for tobacco control when it causes much more death and disease than all other diseases? I do not say that we should not have, even for AIDS, TB, malaria, and many other diseases, funding is not sufficient. WHO and all people, they continue to remind the global community for more and more funding. But tobacco, hardly any funding is available. And in our region, I will also like to place that globally, it is perhaps the India only which has no dedicated program. We have a national tobacco control program with a dedicated budget. Similarly, our legislation is also something which is quite comprehensive. But globally in our region, I also go to the neighboring countries of Bangladesh, Indonesia, or maybe Sri Lanka, Maldives, Nepal, Myanmar. Hardly any country has placed big money for tobacco control, despite the fact that they are suffering from that. So why funding is not there? I want to know. It is not possible to ask me. Normally, I ask this question to the participants that why this is a situation. So simply speaking, still tobacco is not the priority of the governments. Governments are grappling with many economic issues related to tobacco. And so this is one area which still requires support from all of them, and especially the people who are today in today's training. It is for them that right now Government of India money is available under NTCP. Please try to use that money. Please try to ensure that you are effectively able to establish the system which has been advised under National Tobacco Control Program. Next, please. So very quickly, this is a little bit a picture of global burden. What is the global scenario? So almost we have a big, huge burden globally as far as tobacco is concerned. So what is the situation in our country? Next, please, very quickly. So we have where is the information? So right now, many of you are aware of many studies which have been done in India related to tobacco to estimate tobacco burden. But this is something which I wish that you please keep in mind. It is GATS, Global Adult Tobacco Survey. So last survey which was done, so that is called GATS 2 in 2016 and 17. That was done in 30 states and 2 union territories, and it covers almost 99%, almost 100% population of the country. And it is a survey. Please see the last but one bullet point. It is a survey which gives us a picture about tobacco use in persons aged 15 years and above. Next, please. So according to this survey, currently we have, please see, we have 267 million, 266.8 million. It means 27 crore tobacco user in our country. 27 crore. And if we see the tobacco use rates, it is almost 29% used tobacco, any kind of tobacco in our country, which males is 42% and females 14%. We used to say that no, in our country, females do not use tobacco. Please see, 14%. And it is much more than the prevalence, overall prevalence of many countries globally. So in India, 14%, which keeping in view the size of our country, it's a huge number. Similarly, smoker. So we have seen that in last few years, the trend of tobacco use have changed in our country. Earlier it was smoking form, but now smokeless tobacco is used by almost 21%. Chewing tobacco and smoking almost by 11%. And you can see the male and female prevalence. But please go through. We will provide you all the technical source material related to this training. So please read it very carefully, especially for your states also. Next, please. Next, please. Next. So if we see in globally we have so globally we have 7 million deaths, and in India we have 1.3 million, that is about 13 lakh. If exactly we want to say 1.36 million, that is about 13.6 million deaths, out of which broad figures are that 1 million, that is 10 lakh, are because of smoking forms. Although the smoking prevalence is less, but still it causes more deaths than smokeless tobacco. And almost these studies by Dr. Gupta and others that shows that smokeless tobacco causes almost about 3,70,000 deaths because of smokeless tobacco in our country every year. Next, please. So this is a very quick, just to share with you what has been achieved. If you ask me in last 10 or 15 years, I mentioned. So we can say that perhaps I won't say, but perhaps experts are there. They will also say, tell us whether we are on right track, whether what we are doing that is sufficient for us for tobacco control in the country. So what we see that GATS 1, which was done in 2009, and GATS 2. So tobacco use prevalence has gone down in our country, overall prevalence. Similarly, for smoking prevalence from 14 to 11%, that is, there is also improvement. Similarly, for smokeless tobacco, yes, there is some improvement. And dual user, there are some people who use both kind of tobacco. So there is a reduction in overall reduction in tobacco use prevalence in the country. But if you specifically want about your state, so please go through GATS data and please look at your state. It is not the scenario in every state. Many states have not shown a significant improvement, but few states have really done some wonderful work in reducing tobacco use prevalence. Next, please. So this is state-wise. So you can say that Goa is the lowest tobacco use prevalence state if we see any kind of tobacco, and highest it is Tripura. Next, please. Yes, similarly for smoking form, Maharashtra has the lowest tobacco use prevalence and Mizoram has the highest. Yes, please. And for smokeless tobacco, Himachal Pradesh has 3.1% tobacco use prevalence, and Tripura again has highest prevalence. Next, please. So BD smoking is even. So often people say, no, BD is herbal, BD is not a harmful. So already study, Dr. Gupta is again here, our guide in this case. So whose study, Mumbai cohort study, clearly demonstrates, shows that yes, BD is harmful, and rather it causes excess deaths in tobacco users than other forms of tobacco. Next, please. And tobacco and non-communicable diseases. Yes, it is a risk factor for all 4 major non-communicable diseases. Next, please. And environmental burden, huge environmental burden. 10 billion cigarettes are disposed in the environment every day. 10 billion. And 1 billion is equal to 100 crore. 1 billion. Our population of India is 1.3 billion. So 1 billion is 100 crore. You can imagine the number of cigarettes which are disposed of in the environment every day. 7,000 toxic chemicals. So estimated and huge burden, almost about 8 kilogram of fuel would be used to produce 1 kilogram of Virginia class flue cured Virginia tobacco, which is produced in many of our states. High quality tobacco, and 80% of this tobacco is exported to other countries. And deforestation. So this is leading to deforestation, loss of biodiversity, exposure to hazardous chemicals, etc., which is leading to damage to our environment. Next, please. Next. So another, I think, another important area which is now being looked at already, it is environmental impact of tobacco product waste. Almost 6.3 trillion cigarettes smoked globally every year. Almost this much huge waste paper, cellophane, foil, glue, etc. Huge tobacco product waste which is being generated globally. And in India also, more than 100 billion cigarette butts are being dumped in the country every year. 100 billion. Please see. 100 times than our population. Economic cost, again a cost recently released a study by Ministry of Health done with support from WHO, and huge burden, huge economic burden. You can say $27.5 billion US dollar, which is 177,000 crore rupees, which because of direct costs and because of indirect costs. And it is almost 1.04% of GDP. And please see the third and the fourth bullet point. For every 100 rupee which we receive as excise tax from tobacco products, we are spending, society is spending 816 rupees on the cost through consumption of tobacco. So this is the burden of this major disease. And you can see the smoking attributable deaths. So this report is available, and this is recently published in Journal of Nicotine and Tobacco Research. So please read all these material in detail for further understanding of the issues. So this report has also given few recommendations that country should consider increasing taxes on tobacco products on annual basis. It should be regular process without exception to make it unaffordable. And the country should also consider increasing investment in National Tobacco Control Program for effective implementation of tobacco control and broad-based MPOWER policies. Next, please. So in summary, yes, tobacco is a leading cause of preventable premature mortality worldwide. It kills almost 7 million people, 70 lakh. If we do not do anything, 8 million people will die. We have about 268 million tobacco users in the country. It's a major risk factor. And NCD action plan. People often ask, what are our targets for tobacco control? So please see the last line for your ready reference, that we need to reduce 30% reduction of tobacco use by 2025, but it does not stop us to doing more. So please plan in such a way, and we are very much hopeful that if we work more, if we focus and really prioritize tobacco control at national and sub-national level, further prioritization I am saying, so we will be able to achieve those targets. So thank you once again, and once again apologies that I have to run through these slides and also cannot discuss with you face to face. Over to you, Dr. Nidhi. Thank you very much.
Thank you very much, sir, for such an insightful session and acquainting us all with what kinds of all burden tobacco can cause, not just health or economic, but also to the environment. So thank you once again for the session. Before I invite our next speaker for the session on WHO Framework Convention on Tobacco Control, I would like to make a small request to all our speakers to kindly respect the time so that we can run parallel with the allotted timelines. So for taking this next session forward, that is WHO FCTC and MPOWER Policy Package, ladies and gentlemen, please join together in welcoming Ms. Vineet Gill Munish, who's the National Professional Officer of WHO Country Office of Delhi, to kindly come and take the next session. Welcome, ma'am. The now floor is open for your session. Thank you.
Thank you so much, Nidhi. Renu, can you give me the screen so I can open, or will you run my presentation? Either which way works. Can you allow me to share my screen? Yeah. Can you all see the screen?
Yes, Vineetji.
Oh, wonderful. Okay. Let me just, okay. So, yes, thank you, Dr. Rana, for walking us through such an interesting session and building the platform for the next stage. As I shared with you all earlier, FCTC, about the genesis of FCTC and the Empower Policy package, let me just quickly walk you through the next steps.
Full screen. It's still on the.
Okay. How do I do that?
Just at the end bottom right side, there is a slide.
Yes, got it. Thank you. Yep, here I am. Okay, thank you, Amit. So let's start the process. So as we shared earlier, the WHO FCTC Framework Convention is the first global health treaty which was negotiated by WHO. And it was actually developed because tobacco control is such a multi-sectoral, it needs a multi-sectoral, multi-country response. And tobacco advertising promotion transcends countries' borders. So it was very important. This was recognized by WHO and member states, and they came forward with this treaty. And the treaty actually, was developed in 2003, and it entered into force in 2005 after 40 member states had ratified it. As I shared earlier, India was the 7th one to ratify. Currently, there are 181 countries who are parties to the treaty, including EU. Now, what does FCTC say? What are the basic tenets of FCTC? So there are two types of ways of dealing with tobacco. One are the demand reduction provisions, and the other are the supply reduction. So when we talk about demand reduction, there are price and tax measures. That is, if you increase taxes, consumption will come down. Protection from secondhand smoke. As you're all aware, secondhand smoke is harmful. So how do we protect people from that? Content regulation, disclosure of contents. This is, what the tobacco testing labs do. They check not only the contents, but also emissions and the design components of tobacco products to see, what is in them, all the harmful constituents, and also disclosure. How do the tobacco companies disclose to the governments exactly what the contents are? Then packaging and labeling, which of course there'll be more presentations, putting warnings on the pack itself, education awareness, bans on advertising, promotion and sponsorship, and tobacco cessation program. So this is articles 6 to 14. Then come the supply reduction provisions, which are Article 15, which is elimination of illicit trade in tobacco products, prohibition of sales to and by minors, support for many countries. And India, as Dr. Rana shared, we are second only to China. And for this once, we are happy to be second to China. Because we are the world's second largest tobacco producing and consuming country. So we have a huge population who's engaged in tobacco growing and BD rolling and etc. So we need to provide viable alternatives for them, protection for environment, liability, research and surveillance. So the ones in blue are considered the good buys of not BYE buy, BUY buys of tobacco control, which are the basic foundation for the multi-sectoral engagement. Now, out of this whole, menu card of options, as I shared earlier during the inaugural, six key policies were selected, which are the most impactful ones. One is monitor tobacco use, protect people from smoke, offer help to quit, warn about dangers of tobacco. Warn comes in two ways. You put it on the pack, as well as any, national or state campaigns to warn about dangers of tobacco. Enforce tobacco advertising promotion bans. We call them TAPS bans as for short. And of course, the most important one, which comes last, is R, which is raise taxes on tobacco. So these are the 6 key policies. If implemented in any member state, you can be rest assured that tobacco control will be covered to a large extent. So again, this is the 6 strategies. Now let's look at all 6 strategies from the Indian perspective. How has India done for Empower? The first one is monitoring. We've had, tobacco surveillance is part of the National Tobacco Program. There are dedicated funds available. And in fact, there is something called the Global Youth Tobacco Survey, GYTS, which has been conducted 3 times already, 2003, 6, 9, to find out how many children are using, 13 to 15-year-old students are using tobacco. And the last number was about 14%. And 2 rounds of GATS have been conducted, 2010 and 2017. And these GATS were conducted with Government of India budgets with technical support of WHO and CDC. Then some of the tobacco control key questions, which we call TQS, tobacco control questions, have been added to the National Family Health Survey and other surveys. And the Global Youth Tobacco Survey of 2019, which is the 4th round, has just been completed, and you will be finding data very soon on your tables, and you all will be releasing it shortly, maybe in the next few months, which give not only national data, but for the first time, also state level data of tobacco usage among adolescents. So I would say India is doing very well on monitoring, and the key indicators are all taken care of. This is what the GATS showed us, that nearly 29% of adults, that's every 3rd person is using tobacco in some form, every 5th person uses smokeless tobacco, and 1 in every 10 adults smokes tobacco. There are 26, almost 27 crore users. So out of our 1.3 billion population, a large number are using. Out of that, about 200 crore are smokeless tobacco users, and about 100 crore are smokers. So clearly the smokeless tobacco users completely outweigh the smokers. And then there's another 30, few million people who are using both. Now, moving to protect, which is protect people from secondhand smoke, especially vulnerable populations like women and children, and the ones, and especially pregnant women where both the fetus and the mother are exposed. So as per the Section 4 of the Indian Tobacco Control Act, all smoking in public places is banned. Smoke-free rules were implemented with effect from October 2008. So we just completed 12 years of implementation. Public places are defined as workplaces, hospitals, educational institutions, open auditoriums, stadiums, and there's a whole list, including pubs and bars. But there is a small lacuna in the Act. The Act allows for designated smoking areas in hotels with more than 30 rooms and restaurants having capacity of 30 persons. So this is where I think we sometimes, many times, fall short of we cannot protect people, because with 30 persons or more, it's the smoke is getting to everyone. So this is one gap area which we all need to work on. All civil society organizations, state governments have worked very hard, and advisory was issued to ensure that it is mainstreamed into license issues to food places and eateries. There was a toll-free helpline to report violations, and also another law came in, a new rule came in, that no service will be allowed in the smoking areas, the space that is provided at airports and at hotels and at restaurants. And of course, there has to be a board. You see this board, no smoking area, right here, and this board has to be put up at every public place. Dedicated campaigns have also been launched to create smoke-free public places. Coming to O, we've done M, we've done P, monitor, and protect. And we come to O. Now, O talks about tobacco cessation. How do you help if a third of your population is a tobacco user? Then obviously a quarter of your population is a tobacco user, then you have to help them to quit. So tobacco cessation is a vital component of the National Tobacco Control Program. The guidelines you see right here have been developed, and there's about over 400 tobacco cessation centers to be set up in district hospitals under the national program. Counselors are also appointed under the NCD program to provide tobacco cessation services as primary level, that is at the CHC level. So there has been some amount of integration between the NCD and tobacco control program. All dental colleges to set up cessation facilities. There's a functional quit line, National Tobacco Quit Line, 1-800-112356, which has hubs set up in Guwahati, Bangalore, Mumbai to address language and other issues. Counselors are available to answer the queries and provide counseling for tobacco users to quit. Another service is available, which is a mobile-based, SMS-based service called M Cessation. Anybody can register on this by giving a missed call on this number, 229-01-701. And also another interesting, Dr. Rana was talking about TB this morning. So there's a national collaborative framework which has been developed for TB and tobacco. Many national campaigns have been done to raise awareness. Some of you would remember this was done about, if I remember correctly, 10 to 12 years ago. And this is Sunita with our Honorable Health Minister. And she was an oral cancer patient. And of course, unfortunately, she passed on. She died despite having the surgery. If you see, her face is quite damaged, and she did a campaign too. So a lot of, and then the other interesting, what I spoke earlier during the inaugural, the tobacco-free film policy, that gives huge free time, airtime, about 100 seconds per film or TV program to give anti-tobacco awareness messages. Also 85% health warnings, as you would see on packs, that has already been done. Funds are also available to the states under the district and to the state and district tobacco control cells to do localized campaigns for raising awareness. And these are the pack warnings, the latest ones, which will come into force in December 2020. These are real patients from Tata Memorial Hospital whose pictures have been shared. And also this has the message, the picture, the message, as well as the quit line number. So anybody can call this number. Enforce. So India is doing well on the pack warnings, but mass media campaigns have recently seen a bit of a decline, and that's an area of concern. So all of you working in the states, please try to focus on raising awareness. Enforce TAPS. As I said earlier, we call it TAPS. It's the Tobacco Advertising and Promotion Ban. As per Section 5 of the Tobacco Act, this is completely prohibited, tobacco advertisement, and it also extends to depiction of tobacco products and their use in films and TV programs. And many letters have been sent to state secretaries for implementation of rules which ban. So now what the pictures here you see are the point of sale boards being removed. These are not allowed. These are violations. So a lot of support for this has been seen, but much more needs to be done to enforce this. And a steering committee was constituted to monitor these violations. The last one, the R, raise taxes. Government of India has implemented GST from July 2017, where tobacco is listed as a demerit good and kept in the highest bracket category of 28%. Tendu leaves also attract a GST And BDs, however, are not at the 28% level, but are kept at a lower level, which is a cause for concern because they are equally harmful as any other tobacco product. Over and above, there's a cess has also been imposed on all demerit goods except for BDs. And generally, it has been seen that indigenous products like BDs are taxed at lower rates. WHO, in collaboration with Ministry, Dr. Rana gave the numbers earlier, has commissioned studies, one on the economic burden of tobacco and tobacco taxes in India. This study of 2014, which we've just finished and released the next one of 2019, it shows that 1% of GDP, 1% of GDP of this country is lost due to tobacco use. And that is, the kind of investment that the government of India makes, a little over 1% in health. So as much as the total investment of the government in health is, the same amount is sucked out by tobacco use. So that is the stark reality of tobacco use, and which is why, this message, raise tobacco tax, death and disease goes down as tobacco tax goes up. Now, every 2 years, WHO releases a report on the global tobacco epidemic. And this actually captures how MPOWER is actually, implemented in various member countries. So if you see, nearly 5 billion people, that's about 65% of the world population, are covered by at least one MPOWER strategy. And only one, though, not all 6. So about little over half of the world's population is covered. But the one, and now if you see the numbers, pack warnings is almost 52%. So it's the highest. And the lowest being taxation, that's the R, raise taxes at only 14%. And the other one, which is pretty low also, the two are, mass media, as well as smoke-free environments and advertising bans. So if you see between 2007, since when the GTCR, the Global Tobacco Report was started, 2007 to 2018, this graph captures how much progress we have made on MPOWER measures. So as you see, maximum progress has happened in pack warnings, from 5% to 47% of the world's population is covered now. And the least progress had happened in mass media. Actually, it's showing a slightly, stagnating trend, which is a cause for concern because mass media is a very important component of tobacco control. And the others, of course, taxation has seen some increase, advertising ban. The other highest increase has been under cessation programs. At least one MPOWER policy, 136 countries, the red shows the number of countries. So they went up from 43% to 43 countries to 136 countries from 2007 to 2018. 2 MPOWER policies implemented, went up from 11 to 82 countries. Now monitoring, if you see monitoring, that is tobacco surveillance, it went up to 61 countries to about 74 countries. It was higher in 2016, but sort of came down a little bit. If you see smoke-free legislation, it has been growing slowly, but quite the trend is upwards. Went up from 10 countries to 6. Went up from 10 to 23 countries in this period. But the population covered jumped up because countries like India, developed strong. So the population covered has gone up substantially, covering 32%. But the number of countries little over doubled in the last 10-11 years. Coming to health warnings, which is the best implemented among all the MPOWER measures, it went up from 9 countries to 91 countries. and the population from 0.4 to almost 3.9, almost 4 million. So this has seen the best implementation so far. Now looking at how many, the campaigns, and that, as I showed you, has completely stagnated, and in fact it went up a little bit in 2016, but as actually so only 39 countries are airing mass media campaigns. TAPS ban also has seen a gradual sure increase, but still only 48 countries and 1.3 billion of the world's population are covered by this Empower measure. Tax again saw this jump from 23 to 38 countries, and about close to 1 in 5 is now protected due to raising taxes. Now looking at having a national agency, like I mentioned earlier, Government of India has a clear dedicated fund and dedicated resources for tobacco control. Only 1 in 4 countries have it, and so that is it went up from 42 to 57 countries, staffed by at least 5 full-time equivalent people. But it's very, very heartening to see that Government of India, if you see the total number of people, it would run into a couple of thousand who are working on tobacco control if you cover all the state, district focal points. So we actually have a very, very strong program which is well funded. So Dr. Rana earlier was talking about funding for tobacco control. Actually, it's not only funding for tobacco control which is less, it is the funding for non-communicable diseases which cause the maximum morbidity and mortality are the least funded actually. So within NCDs, possibly tobacco would be well funded, but NCDs itself is very low funded. So that's an area which all public health global experts are not happy with, and are encouraging governments, donors, philanthropists, and individuals to focus more with funding coming into NCDs and into tobacco control. But India, in that sense, we have a much better status for this particular indicator. Looking at taxes at a glance, now this is the Southeast Asia region. The gold standard is that tobacco tax should form 75% of the retail price. So if a pack of cigarettes costs 100 rupees, 75 rupees in that should be contributed to tax. So how do we look? This is, by the way, only for cigarettes. This because smokeless tobacco is more a problem for India and for Southeast Asia. This captures only for cigarettes. So if you see, we are at India is at 54%. Which is way below the level of that 75%. But there are other countries, Bangladesh is at 71%, and Thailand is actually at 77%. And Maldives is at about 68%. So now this gives you a chart of, what is the percentage of smokers in a country. This is only smokers again. How many are doing the monitoring? So this is a chart to measure, and this is how this is our report card really, and we like to see the least number of reds in this. But of course, India is blue in most cases, but a lot of more work is needed in many areas. So with that, I take your leave. Thank you for listening so attentively, and thank you to the union again for giving WHO this opportunity, and thank you for sharing more about the WHO, FCTC, and Empower at national and subnational level. Thank you so much.
Thank you once again, ma'am, for such enlightening session and giving us all the details and provisions on FCTC, and also highlighting the demand reduction provisions and also the supply reduction provisions ingrained within FCTC. Also elaborating on the explicit components of MPOWER, and also telling us how we still need to work on most cost-effective interventions, such as raising taxes as compared to the other countries in the region. So once again, thank you very much, ma'am, for such an enlightening session on FCTC and MPOWER policy package. So
maybe before I go, there's a question from Srinivas Joshi, which I just quickly in 30 seconds like to respond to. Yeah, thank you, Srinivas, for the question. It's a very good question because yes, we have, it's not only porous borders only for states, it's also for countries. Like, we have porous borders with several countries around us, and not only taxation, also, mass media campaigns become a problem because there is cross-border advertising, there is cross-border movements of tobacco products. So yes, ideally, the recommended strategy is that there should be a comprehensive taxation policy across tobacco products so that there is no substitution, and there is also a comprehensive policy so that products are not cheaper across states, especially states like, let's say, NCR, where you have 3 states. But this is a genuine problem not only for India. It persists even in the US. If you see, states like California have higher taxes, so there is some cross-border movement. But that is what the illicit trade protocol also, as you also mentioned, smuggling. India is has also assessed to the illicit trade protocol, which will ensure, as it's implemented, that these sort of imbalances are taken care of. Thank you for that good question.
Vinitji, thank you very much. Just about Srinivas Joshi ji, so I just saw him. Mr. Srinivas Joshi is a retired IS officer from Himachal Pradesh. And,
thank you, sir. Sorry, I did not. Thank you so much, Srinivas ji, for that question. And
very passionate when I was working in Himachal Pradesh. So he is very passionate about tobacco control, and really, I think the way he worked with government even after retirement. So really, it was a big support to Himachal Pradesh Voluntary Health Association, and he worked closely with Dr. Gopal Chauhan for almost now it is more than 1 decade, and especially he works closely with children and youth.
Thank you, Dr. Rana, for introducing us to Srinivas Joshi ji, and thank you, Joshi sir, for all that 1 decade of contributing, and especially to the youth. I think that is the most vulnerable population. So thank you again, and thank you for that. Was a really good question.
Ma'am, we do have one more question for you from Dr. Rakesh Gupta sir, and he mentions that why there is no report on cessation in the report 2018. Would you want to elaborate on that? There's no date.
Hi, Dr. Gupta. I think there wasn't it there in the slides? Good to see you, sir. Okay, maybe we missed that. No, but there is a clear indicator for cessation also. I'm sorry if I missed that. But all MPOWER, all 6 MPOWER are covered under.
No. The last slide on CRO, last but one slide, which was on CRO, where you're given the percentages for other indicators. Okay. I saw the entire column on cessation totally blank. That's why I asked you this question.
No, sir, that is not blank. You see, each color represents a level of implementation.
Okay.
So those lines are another level, but each color of blue. I'm sorry, you can't see the the colors and what they mean. Yeah. It's not blank, sir. India is doing very well, so we are well represented there actually. Thank you, sir.
Thanks.
Thank you, ma'am, once again for taking up those questions. And now we move to the next part of this particular session, which is to address National Tobacco Control Program and overview of the progress, achievements, and way forward. To take this very session, may I please welcome Dr. Rana J. Singh, Deputy Regional Director, the Union Southeast Asia Office, New Delhi. Sir, I would also like to bring to your attention, there is another comment by Srinivas Joshi, sir. So if you would kindly address that regarding considering schools for promoting tobacco control. Thank you, sir. Over to you.
Let me see which is comment. So Pranay has also given, and there is comment from Dr. Gopal Chauhan also. I hope that GST will solve this problem if the slab is high. So there is a comment from Pranay also. Thank you very much to all of you. I think in the interest of time, Pranay, will you like to say anyone?
Dr. Rana, I would like to request that we should move on. We are already 14 minutes.
Okay, yes, thank you very much. So there is just before I move to NTCP, there is another comment from Mr. Srinivas Joshi that about that 80,000 to 100,000 youth become a regular tobacco user. So Mr. Joshi, thank you for sharing this study, which you are mentioning that 80% of smokers started smoking in schools. You see what I said that this many people. So this is again very something old data. It is a report from World Bank, which is curbing the epidemic. Which was released in 1999, curbing the epidemic. According to that, 80,000 to 1,000 youth become a regular user, means they become addicted. So starting smoking or starting tobacco use or trying a smoking form in school, that is a separate part. But addiction, so there is a definition for addiction when you need nicotine and you cannot stop it. So that is something which I shared with you. So thank you for sharing that study also with us. So very quickly, now Dr. Swasti Charan is traveling and with his permission, and so I am just want to share with you, because this session is about setting the scene. Before we really move on to individual component of MPOWER in detail, just to share with you what is happening. So another important area is India's National Tobacco Control Program. And what is the role of National Tobacco Control Cell, State Tobacco Control Cell, and District Tobacco Control Cell? Why we have included it? Although we have separate NTCP trainings also, but because again I mentioned that in this particular training, almost I see that 80% of our candidates, they are new one, who are first time attending such a you can say detailed training. So over to next please. Next. So we are aware of the burden of tobacco use. Please keep all those figures. Now you should remember what is the current burden of tobacco use. So this is about comparison between GATS 1 and GATS 2. So already you know there is a reduction in tobacco use prevalence from 35% to 29%. So currently overall tobacco use. Similarly, we have 11% smokers and almost 21% smokeless tobacco user in the country. So this is a comparison between 2009 and 2015 and 16 when GATS 2 was done. Next, please. So now, after signing of FCTC, and at the same time, while the FCTC was being negotiated at that global level, India was also working on developing its own legislation, which is called COTPA. So our COTPA almost came just before FCTC came into being. And thereafter, to effectively implement FCTC COTPA and implement various other provisions of FCTC, which also recommends that all countries should have their dedicated policies and programs to reach every individual in the country. So how that can be done? So that was possible through a national tobacco control program. So India developed and designed a program in 2000. So it was a small pilot program in 2000, which was done in 2006 and started implementation in 2007. So why a program was required? Complexity of tobacco use in India, very, very important. That in India, the tobacco use is not as simple as in many Western countries where there is only cigarette form of tobacco use is there. Here, we have so many only smoking form of tobacco. In addition to cigarette, we have many forms of smoking forms, and similarly smokeless tobacco, and many people who are dual tobacco users. So really tobacco use issue is complex, very complex, and within all these segments, every issue, whether it is a cigarette, whether it is BD, whether it is smokeless tobacco, and various kinds of tobacco use in different regions, whether it is Gadakhu in Madhya Pradesh and Chhattisgarh, whether it is Tabur water in Mizoram and Zoziel, locally made BD or cigarette in Mizoram. So we have very different kind of tobacco use in the country. Complexity of stakeholder, as I mentioned in my earlier talk, it is not only public health issue. Multi-stakeholder engagement is required, and how we can ensure for that. Similarly, we need to identify various strategies for different sectors. So there are different stakeholders, so different strategies are required. And NTCP acting as a central program that will help sensitize all stakeholders, increase awareness, help raising policy and legislation issue, help implementation of related public health and legislation related to tobacco control at sub-national level or state level or district level. It's a public health problem in India, and like other need a national level program. So just you are aware that whether it is health or beyond health, whether it is any program in our country, district is our ultimate unit. It is the states which implement their programs, any program beyond health also. So that is why a program is required for effective implementation of various tobacco control policies. And we also now obligated through FCTC that we need to have a dedicated program with dedicated budgets to control tobacco in our country. Next, please. Next, please. So what are the goals? So please see, first goal is prevent initiation. Second goal is promote quitting, very, very important. 267 million tobacco user in our country. And for me, as a public health person, for many of you who are a public health here, quitting is such a thing which requires a lot of dedication from the service provider, as well as a lot of efforts from tobacco user perspective also. So we have 267 million tobacco users, and as per WHO definition of addiction is a disease. You can imagine these are patients for us. This is such a huge burden. Eliminate exposure to tobacco smoke is another goal of NTCP. Then reduce demand by awareness generation campaigns, by banning tobacco advertisement, promotion and sponsorship, and through pack warnings, graphical health warnings, just shared by Vinitji, and reduce supply by restricting access to minors, and thereby reduce tobacco-related morbidity and mortality. So these are our broad goals of National Tobacco Control Program. Next, please. So very quickly, as you are aware, a National Tobacco Control Cell, please, again, remember all these things. Tobacco Control Cell that was established in NTCC, we call it as NTCC, that was established in February 2001 to provide impetus to tobacco control efforts in India. And once a National Tobacco Control Cell was established, that started working on COTPA and National Tobacco Control Program. So we have a legislation, Cigarette and Other Tobacco Products Act, under which there are various provisions, section 4, 5, 6, 7, 11, and many other sections are there. So that we will discuss as we move towards our program. And then India ratified WHO FCTC in February 2004. So this is, in short, history of India's national tobacco control tobacco control program. So there are various levels. Central government has important roles. I am not mentioning here. So first of all, central government needs to provide overall leadership to tobacco control in the country. Central government needs to give us those legislation and policies. Central government is providing main responsibility is to provide trainings and capacity building across the country. So developing resources for various training programs. Central government or National Tobacco Control Cell's responsibility is that providing that major IC activity in the form of mass media. There are some IC activity which are happening at local level, but central government is working and all those mass media campaigns which you are seeing. There are central government or National Tobacco Control Cell has also established national tobacco testing labs. So there are many things which National Tobacco Control Cell is doing. One is also they were supposed to set up a National Tobacco Regulatory Authority for effective enforcement and monitoring. Then there is a state tobacco control cell, and then there is a district tobacco control cell. I think many of you are aware of the activities to be done by them. Next, please. We started the program way back in 2007-8 in the pilot phase in the 9 states and 18 districts. So these are the 9 states. In second phase, we started in 2008-9. So when 12 new states were taken. So in that way, pilot phase 1, phase 2 had 42 districts in 21 states where this program was established, was initiated. Program of National Tobacco Control Cell, there is NTCC. Am I audible?
Yes.
Okay.
Yes.
Thank you, Dr. Sinha sir. Next, please. Next slide. So yes, so I have already mentioned central level activities of National Tobacco Control Cell. So yes, so it is National Tobacco Control Cell is also working on supply side, many supply side issues, alternative crops and livelihood, then surveillance, which you already heard of, Global Adult Tobacco Survey, Global Youth Tobacco Survey. So these are all responsibilities of central level activities. Next, please. Next. So there are now state tobacco control cell. No, please go to the previous one. So there is a state tobacco control cell. And under that, the main responsibilities are to do awareness generation activity, advocacy efforts, to ensure every department is properly involved, multi-stakeholder engagement, training of key stakeholders, including enforcement officials, school teachers, then state level coordination committee, meetings to organize SLCC, state level coordination committee meetings, those who are new colleagues, that in every state, at state tobacco control cell, there is a state level coordination committee, SLCC. Similarly, they also need to plan enforcement of COTPA in the state. Similarly, they also need to do monitoring and supervisor of implementation in all the districts within that state. And they have a budget in the form of flexi pool also to provide to the states to cater to specific needs. They can decide a few activities which they feel that these are important and crucial. So states have got that budget. Similarly, at state level, there is some staff which is given under the program. There is a state consultant, there is a legal consultant, or there can be finance consultant also. In few states, we have both state consultant as well as one of the other one. We have a program assistant, data entry operator. We can share with our NCD control program. Next, please. Similarly, we have this is a budget which is available for the state tobacco control cell. So what amount of budgets are available, but it all depends on how much you ask in your PIP, project implementation plans, how quickly you give your expenditure statements, how quickly you give your utilization certificates, and I think and how effectively you are able to negotiate within NHM broader framework for more budget. Next, please. So very quickly, please. So similarly, we have a district tobacco control cell. There are various components. You can see training, awareness generation in the form of IC, cable TV, street flow. This is all something which you need to decide at your level in your states. So there are school programs. There is now that has been increased from 50 to 70 per year. There is monitoring of enforcement of tobacco control laws, tobacco suggestion center. So each district in the country will have to establish a tobacco suggestion center in addition to community suggestion where even health workers need to be involved. How a health worker can also provide basic tips of quitting. So these are few pictures from highest level, from national level trainings to the trainings happening in a PSC or in a sub center. We need to train health workers, health professionals, law enforcers from all departments, NGOs, women help groups, etc. Next, please. Next. So similarly, we need to do awareness generation. Please, this is something which is which budget is available for local level activities. Big mass media, which you see in various television channels, that is designed and implemented by Government of India, Ministry of Health. But this is something which you can do at your state level, district level, taluka level, village level, whatever you want to do. Next, please. Next. So similarly, we have school level activities. So most of you are already doing it. There is a budget available for all those school level activities. There is guidelines available how we need to do our school level programs. Next, please. Then we have monitoring. So implementation of the law. So this is very crucial. Please remember many. So I always say this one thing. Simply awareness generation will not do tobacco control. That is why that now we have a law, and when there is a law, it has to be implemented. There is no alternative to implementation of law, enforcement of law. Awareness generation is not an alternative to enforcement of legislation. They have separate rules. So we need to see that all provisions of COTPA and other related laws, maybe our colleagues will share what are the other related laws, so that needs to be effectively implemented and monitored. Next, please.
So may we please request you in view of the time?
Final, yes, final. So there needs to be a district tobacco control cell, tobacco station clinic. We also heard of other ways of tobacco cessation, that is a national tobacco quit line established under this program, then M cessation program, then integration. Vinithji has already shared integration with TB, oral health, NCD control program, Ayush. Thank you very much. Next, please. So next, please. So budgets are available for district tobacco control activities. Next, please, for tobacco cessation center. So here I just want to just to share with you that we have a dedicated program. Now, program implementation is variable across the country. Few states are doing excellent work. excellent work. And for example, I would like to mention few states, and definitely Uttar Pradesh comes to be first. One, Rajasthan is one another good state. Yes, Punjab, another good state where they have been implementing. Himachal Pradesh, many other states they are doing. But please also see that the budgetary allocations which have been done, they are used. Staff is very important. So all states must hire the staff which have been allocated. Few states have been doing good, but as far as NTCP expenditure is concerned, that is not happening up to the mark. So please read it more. A lot of other details are available. We have NTCP operational guideline, which we will provide to our participant also for further reading and for further understanding of the program. Thank you very much, and over to Dr. Nidhi.
Thank you